Hello, and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, a community pediatrician and your host for today's episode. I'm very excited to welcome today's guests, Dr. Halley Wasserman and Dr. Chineze Ebo from the Division of Endocrinology here at Cincinnati Children's. Today's topic is precocious puberty, something that we are asked about very frequently in the office, so very excited to have some experts here to help answer all of our questions. So first of all, Dr. Wasserman, Dr. Ebo, if you could take a minute to introduce yourselves, tell us a little bit about your background, your training, any special interests within endocrinology or even outside the hospital.
All right. Thank you so much for having us. As mentioned, my name is Halley Wasserman. I've been with the Division of Endocrinology since 2016, and I'm an associate professor there. My main area of interest is in pediatric bone health, but it overlaps a lot with this topic because about 40% of the skeleton is built during those pediatric years, with the puberty hormones playing an important role. And so I have a lot of extra interest in disorders of puberty as well with that overlap.
Hi, thanks so much for having us. So as mentioned, my name is Dr. Chineze Ebo. I am a third-year pediatric endocrinology fellow, and I have a lot of interest in puberty. I am interested in health equity within endocrinology, and one of my focuses is currently on understanding any sort of disparities in the management and treatment for precocious puberty. So this is an interest of mine as well.
Great. Well, let's start with talking about normal pubertal development. You know, in our office, we're seeing kids of all ages, at all stages. We're often asked by parents, is this normal, or when should I be expecting, certain changes both in boys and in girls? So could you guys give like a brief overview of the normal timing, the normal tempo of puberty, and maybe a little bit how that's changed over the years?
Sure, yeah. So normal puberty for girls usually happens between ages 8 and 13, and for boys is usually between 9 and 14 years old. In girls, puberty typically starts with breast development or thelarchy, and this is followed by pubarchy or pubic hair development. And then menarche starts about 2 to 3 years after the onset of breast development. You can typically see the pubertal growth spurt right before that onset of menarche as well. For boys, puberty typically begins with testicular enlargement, followed by pubarchy, and then you'll have development of other secondary sex characteristics, things like voice deepening and increased muscle mass. Girls typically complete puberty anywhere between 15 and 17 years old, and boys are between 16 and 17.
And when you say complete puberty, what do you mean by that?
So the completion of puberty meaning they have completed their growth for the most part. Girls have now gone into a fairly consistent rhythm of their periods and the menses, and they have essentially kind of completed those initial phases of puberty.
Okay.
So does that make sense?
I think I'll just add that while those are the ranges, the averages for kind of the onset of thelarchy in girls as the first indicator of true puberty is around 10. And then for boys, the onset of puberty, which is actually enlargement of the testicles, so not as an obvious finding, but certainly something that your pediatricians would come across on well-child exam, that on average is around age 11.
Okay. Yeah, I think that's important for us to understand because a lot of parents, especially parents of girls, are asking, like, well, when are they going to start puberty? And I think to them, they mean menarche.
Absolutely.
But for us to clarify that, actually puberty starts when the breast bud development starts, and we can kind of start the clock to menarche from then. But, a lot of parents, I think, are a little taken aback when, they start to see breast bud development and they just see, they're so young. That doesn't mean their period is starting, but I think in the parent's mind, that's what they see. Now, Dr. Ebo, you had mentioned, growth spurt for girls happens kind of in that immediate time prior to menarche. How long do we usually see that growth spurt last for boys and girls?
Yeah, so for girls, you can see that starting can be within that 6 to 12 month time period. And for boys, they typically have that growth spurt towards the end of puberty. So they'll have their testicular enlargement, they'll start to have these other features, and then you'll see that growth spurt sort of happen towards the end of puberty for them. And again, that's anywhere from 6 to 12 months of growth.
I think I'll hit on those Tanner stages that are so important for us pediatric endocrinologists. There are 5 Tanner stages that people go through, and we always kind of talk about. Tanner 1 is really no physical evidence of any of these puberty changes, no breast budding, no enlargement of the testicles, and no hair in the pubic region. And then the Tanner 2 is those breast buds that parents kind of come to your offices about with concerns. And then Tanner 3 is when those breast buds kind of become more of a breast disc extending beyond the margins of the nipple. Tanner 4 is when that nipple becomes raised, so a secondary mound. And then Tanner 5 is that full adult appearance of the breast tissue. It's a little harder to describe the testicular changes in those Tanner stages because it's all about like volume and size. That's why we actually still use our orchidometers.
Yep.
Those are still in existence, and we pull them out in our clinic visits as well.
We've all seen those in residency and use them, yes.
Yes. The growth spurt for girls is often between that 2nd and 3rd stage of puberty, with that menarche occurring between the 4th and 5th stage, whereas boys don't have that growth spurt until closer to that 3rd to 4th stage. One of the things I often kind of remind parents of is kind of thinking back to those middle school years, how the girls seem to develop faster, they grow taller faster, and the boys kind of often catch up a little bit later from that end.
And probably outside the entire scope of this podcast, but delayed onset, late menarche, or late growth spurts for boys. Is there a hard cutoff in age where you guys would start to get worried, where a girl has not had menarche, a boy has not shown significant progression through the Tanner stages and the growth spurt?
Yes, I think, as you're right, that's a whole topic in and of itself, and I think it lends to some of our discussion that will be coming up, is how it tends to be that the girls present with the concerns for early puberty, whereas the boys often are the ones coming to our offices for the concerns for the delayed puberty. Some of those age cutoffs that we do pay attention to for the delayed puberty is if a boy has not started into any kind of testicular enlargement by age 14, that would be a marker for us. And for girls, as mentioned, no breast tissue by age 13. Extrapolating from there in regards to when do we become concerned if a girl has not had menarche yet, some of it kind of depends on if they have that breast tissue. So if they don't start breast tissue until 12 and a half, 13, they may not have their first menses until 16. However, if they have more typical timing of onset of breast tissue, most of the time if there's no periods by age 15, that kind of is outside our typical progression.
Okay. Well, we will save the rest of that discussion for a future podcast. Let's go to the other end of the spectrum. So, early puberty, precocious puberty. That's something that parents will come in and, especially with girls, because I think the signs are a little more obvious with breast bud development. Where is that cutoff? If you see a girl in the clinic who is having breast bud tissue, who she's having more body odor, that's another trigger that I think some parents worry about and will come to us about. What ages, and for boys too, for the body odor, even some hair development, what ages would you say is kind of the lower end of normal? And then, the next step is, when is it too early?
Yeah. So true precocious puberty, which is the actual evidence of, sex story production in girls' estrogen and in males' testosterone, for girls is defined as having these evidence of this puberty development before the age of 8 years old, and for boys is before the age of 9 years old. I think you did touch on some good points when you brought up body hair and body odor, because I think people typically associate those symptoms with true puberty, when in fact that is coming from a different process that's happening in the body called adrenarche. And so when we can talk a little bit more about this, but when we're trying to assess for true evidence of puberty, some of those things that we mentioned, things like breast development for girls, onset of menses, pubertal growth spurt, and for boys, testicular enlargement, seeing their pubertal growth spurt as well. Those are things that we associate with true puberty. And if we're seeing those signs before the age of 8 in girls or before the age of 9 in boys, that is considered true precocious puberty.
So if we're just seeing just isolated adrenarche, that alone is not, major red flag for, the full puberty process.
Correct.
The adrenarche, the thelarche, the menarche, all of that. Okay, that's good to know. So if we can differentiate between, early adrenarche versus true puberty, kind of what would be the things we'd be looking for?
Yeah, so true puberty is the hypothalamus sending the signal to the pituitary gland, and then that goes to the gonads, so activation of the HPG axis. And that then leads to estrogen production in females and testosterone production primarily in males. And that is those signs of thelarche in girls and testicular enlargement in boys. Adrenarche is where these androgens or male-type hormones are produced from the adrenal glands, and that occurs in all of us. It causes the body odor, the acne, and the hair growth, pubic hair, axillary hair from that standpoint. It's a completely separate process and not regulated at all by the pituitary gland. So I think that's the important distinction to make. Body odor can come from many different sources, and without really seeing any other signs of adrenarche, we don't really have any concern for pathology just based on body odor alone. Certainly, if you're noticing true pubic hair, that coarse, dark, thicker hair, and it's not just the generalized hair that's kind of like all over our mammalian bodies. We're mammals as well, so we're supposed to have that body hair, and different ethnicities can have darker body hair than others. If that's all you're seeing, and even if it is in the pubic region, but it's not that virilized hair, also probably not a concern.
Okay. So if we see just, if they're just the body odor, just the more body hair type, would you even go down the road of a workup, of a lab workup?
Probably not. I know sometimes we do kind of just need to do that to give that further reassurance to the family, and a bone age may be helpful in that scenario, just to kind of show them that there's no skeletal advancement from that end, and that skeletal advancement is always coming from those higher levels of sex steroids, the estrogen and testosterone.
So when we have these kids, looking at their growth chart is often going to be a helpful tool. So, what things should we be looking for in the growth chart when we're kind of trying to decide, is this puberty or something else?
So one of the things that we typically pay attention to is that linear velocity and how fast they're growing. And typically in a prepubertal child, we expect them to be growing anywhere from 4 to 6 inches a year.
Centimeters.
Sorry, I'm so sorry. Oh, no, sorry. It's 4 to 6 centimeters a year. And once we start to get into that pubertal growth spurt, you can see anywhere from 8 to 12 centimeters a year. And so really it's that growth velocity that we're paying attention to assess, are we seeing evidence of, this maturation of the skeletal bones? Are we seeing this rapid increase in their growth that could be secondary to exposure to sex steroids?
Yeah, I think that's so important, is paying attention to that growth velocity curve. A child that has some subtle findings that you're trying to figure out, could this be real puberty or not? But if their growth velocity is maintained on their growth curve, I think you could be reassured to just continue to observe with that, because that increase in growth velocity is really a key finding of true puberty. So
especially the increase, because you have some kids who
have always been tall.
Their parents are tall, and even their growth velocity, I see it more in inches in my chart, so that's, I used to tell parents 2 to 2.5 inches is normal, but there's some kids I track them over year to year, they're 3 to 3.5 inches per
but steady.
year, but it's steady,
yeah.
so that's more reassuring.
And we actually use in our clinic the growth velocity curve that's available within EPIC, and that helps a lot to kind of track that trend over time, see the range there. I think that kind of leads to another point of just with a greater percentage of our children that we see having obesity, and that contribution to growth, being taller stature, and its overlap with also timing of puberty, that is an important thing, and why we so emphasize partnership with our pediatricians and having those annual well-child checks to kind of trend that. We've all had those situations where the kid hasn't been seen in a couple of years, and it's hard to tease out what their growth velocity has been doing with the changes in those missed visits.
So if a family comes in and they've expressed this concern, maybe at a well visit, and we've gone through the exam and we actually do find signs of early puberty. We see actual thelarchy, we see testicular enlargement. What other questions should we be asking? What other the important history factors?
Yeah, I think one of the biggest thing you can get is the history. So is there any sort of family history, understanding if, mom or dad have had, had early puberty themselves, or if there's any siblings who might have had early puberty. Understanding if there's any sort of underlying genetics histories in the family. Some of early puberty can be genetic or familial. Wanting to know what any sort of exposures that child might have had, whether it's through medication, certain creams, what the diet might look like, things that could contribute to having some external hormone exposure. Wanting to know any sort of medical history for the child as well, so any sort of neurologic history, if they've had any concerns for headaches or seizures, vision changes, any neurologic changes that would be concerning for maybe an intracranial pathology will be really important to tease out as well. And then just even asking families, have you noticed, increased growth? Have you had to change sizes in shoes or clothes recently, more, quicker than you would have expected? Just getting more of the history of what's been going on, especially trying to tease out how rapid the progression of that puberty has been. So, the age of when they first noticed the pubertal things, and then how fast they've noticed the progression of those pubertal signs.
And you mentioned exposures, the exogenous exposures. What are some of the common and maybe less common ones of those that we might ask about? Because we might not even know what to ask for, because we don't deal with a lot of those types of medications in primary care pediatrics.
I think the most frequent exposures that lead to more premature thelarchy, or that breast tissue that we've come across, is the use of essential oils for lavender and tea tree. Those are commonly used for stress relief, or tea tree oil is used a lot in lice prevention and things like that. And those very, very concentrated doses can cause some stimulation of the breast tissue from that standpoint. Generally, while we ask about those products being added to lotions or things like that people use, it's a smaller dose in those situations, so less of an exposure there. I think there's a lot of interest in research about PFOAs and plastics and different things in our environment that kids are exposed to as a contributor to the overall younger age of breast development being seen in girls. However, it's hard to pinpoint one thing. And so people often ask us, should we only do organic milk or, non-hormone treated beef or things like that? And it's hard to tease that piece out. And if a family's lifestyle allows for those things, great. It's potentially one less exposure. But in regards to pinpointing that as a true cause, that's not really been our experience in clinical practice.
And on a related note, soy?
Soy does come up as well, yes. It has to be a lot of soy, so it's probably more into your vegetarian diets where they're doing a lot of tofu and things like that.
So 1 cup of soy milk a day is probably not going to be...
Not enough of that phytoestrogen they're concerned about.
And then medications that might be in the home?
Yeah.
What things should we ask about?
Yeah, so obviously any sort of hormonal creams, lotions, supplements.
So that would be...
for instance, I had a patient who... his dad had been using testosterone gel and was applying it to different surfaces on his body, including his back, and had been carrying this child, and so the child had some exposure that way, and then developed some evidence of precocious puberty. So things like those any sort of hormonal creams that are easily accessible in the house or that people are wearing on their body that could then be exposed to the child is definitely something that puts them at risk.
I think I would emphasize the importance of asking about that. Sometimes people aren't disclosing that right away, and they're thinking, well, I'm following all the instructions on how to safely use testosterone, because it's really important making sure that like the parent that's using testosterone is using a separate towel in the bathroom, because it can get transferred after even washing hands. There can still be residual things, and on a small child, that's a really potent exposure from that standpoint. The other thing I often ask too is like, do they spend a lot of time at maybe grandparents' house or someone else where they might be having those creams? It might not be something as common in a younger or middle-aged parent, but if the child's spending a lot of time in an older person's household, they might be more likely to have those exposures. Estrogen pills, and birth control or things like that, it would have to be a lot of exposure that they would be taking, but there are estrogen patches that the child could come into contact with.
And Dr. Wasserman, you referenced the HPG axis that we all remember so well from medical school. So that kind of gets into like, if we do find that it is not an exogenous source, but maybe endogenous precocious puberty. Are there different causes? Like, what are the sources on that HPG axis?
Yeah, so maybe we should back up just a minute. So like in thinking about how do you verify that it is an endogenous cause. So that would be, you may be calling your local endocrinologist for assistance in ordering that testing from that standpoint, but what we would be looking at is to measure FSH, follicle stimulating hormone, and LH, luteinizing hormone, as well as the gonadotropin, or the sex steroid estrogen, or testosterone as indicated in the patient from that standpoint. Here in Cincinnati, we have the options of doing what's called second generation or third generation, and a lot of that has to do with the sensitivity of the assay. So I think when we're thinking about nationwide, you got to kind of know what your lab is running, and so that would be talking with your local endocrinologist to understand that if the pediatrician is trying to help get some of those labs. It's important to get those things first thing in the morning. So that would be another thing. Those levels naturally rise overnight. And so if you see your patient in the afternoon, maybe not grab those labs right then, but have them come back to get in the morning. And then there's cutoffs to confirm that it's true activation of that HPG axis with an elevated LH levels, kind of the most important thing, and FSH is more supportive. But then again, I would say probably you'll be in conversation with your endocrinologist to confirm that. Once confirmation that this is all stemming from the brain sending the signal to the gonads, then there's figuring out why. And in girls, most commonly it's idiopathic, especially if the onset is between age 6 and 8. In boys, they have a higher risk of it being a pathologic cause due to a tumor in that area. And so any boy with the onset of true puberty before age 9 needs an MRI. In girls, that MRI decision sometimes depends on the exact age when it started.
An MRI of the brain?
An MRI of the brain,
at the
yes.
pituitary and the hypothalamus.
Yes,
okay.
Thank you for clarifying that. In girls, sometimes that's a little bit more nuanced of a decision depending on the age of when it started. If they started just at 7.5 and the tempo is slow, you may not have to go down that MRI route just because it is most likely to be an idiopathic cause. As mentioned from Dr. Ebo here, there are some genetic factors that are associated with true precocious puberty, but they're pretty rare overall as well. Like 10% of the cases have been identified genetic source.
Mm-hmm. So if we're ordering just a screening panel, we have enough concerns. So you mentioned FSH, LH, estrogen, and then do we do testosterone or the DHEAS, or kind of which of those sex hormones do you typically recommend us starting with?
Yeah, so as you mentioned, FSH, LH, estrogen if you're, looking at girls, testosterone if you're looking at boys, and then depending on what other clinical symptoms that you're seeing. So if you're seeing concerns for body odor or pubic hair development that seems a little bit more than you would expect, you could go down the route of also obtaining those androgens. So doing like a DHEAS or androstenedione are kind of some androgens that you could possibly look at, just to make sure that we're not concerned of androgen excess that could be coming from another underlying cause.
The other thing we often do is get thyroid levels, so a TSH with reflex to free T4 or free T4 separately as well. And that's because in profound cases of hypothyroidism, there can be signs of early puberty as well. Now, typically that goes back to your growth curves being so important, because with profound hypothyroidism, you would expect to see a slower growth velocity as well, and not an accelerated growth velocity, so that may not fit. But as thyroid is so important in regulating the other hormone systems, we often just grab that at the same time.
And would a bone age be a commonly ordered first test or early test?
Absolutely, yeah. I think bone age is very helpful for obviously assessing if there's any sort of advancement or skeletal maturation that could come from a hormone exposure. But it also, for a child who's rapidly growing, lets us have an idea of what the growth potential is. We're actually able to use the bone age to come up with a predicted final adult height that can let us know, first lets us know if the growth plates are still open, how close they are to being closed, and then what that growth potential might look like. So it provides a lot of information for us.
I will also add that with the bone age, we can sometimes gauge when one might expect that first period, because it typically occurs around a bone age of 13 and a half for girls. So sometimes that's also useful information to gauge how much sex steroid has been exposed, and correlating that with the patient's true chronological age to see, okay, this is the timing, this is our window. We're worried that this child may actually have that first period before age 10.
So if we get these labs and they're concerning or suggestive for true precocious puberty, obviously we're going to be involving our friendly local endocrinologist, but and they're probably going to be managing it. But can you guys speak a little bit about when do we intervene? What tools do we have at your disposal to help?
Yeah, I think that I think it's very patient specific and very individualized, some of these cases and conversations, and a lot of it is shared decision making with the families and kind of what their understanding of what's happening is, what they are hoping for their child, and kind of what the treatment options are. So traditionally, if there is a child who has central precocious puberty, you can use a puberty blocker, a GnRH agonist, and this is something that will just essentially quiet down puberty, so quiet down those FSH and LH levels, and therefore you produce lower levels of those sex hormones and can essentially stop puberty. This is usually used for kiddos who are super young and who you obviously don't want to have puberty. You don't want them to experience menses at a younger age. And for boys, too, who are experiencing evidence of puberty, rapid growth, you want to kind of calm those things down. I think where it becomes more of a conversation is for those kids who are closer to that pubertal age and have maybe shown evidence of slow puberty progression, or for families who are like, I actually, I'm okay with my child going through puberty at this certain time. Do we actually need to start medication or not? Is this something that we could watch and wait and just kind of have them naturally progress through puberty on their own? Or is this something that we need to actively intervene? And so I bring that up because I think this is something that I've noticed in my short time as an endocrinology fellow, that a lot of these come down to conversations with the family and what their overall goals are for their children. I think there are very obvious cases where if this is a 6-year-old child who has had onset of breast development, and that they're going to have their onset of menses at a younger age, it's probably better to initiate some sort of puberty blocker medication to kind of prevent some of the impacts on growth that we can see with early puberty, as well as some of the psychosocial things surrounding early onset of puberty that I feel like we don't talk enough about. Whereas if you have, someone who's 7.5 and, puberty, they just started noticing pubertal development around 7. Things are going slow. They're not really seeing an impact on their growth. This might be a child who you hold off on medication, just kind of watch them slowly, have their pediatrician monitor their growth, and just let them go through things naturally. So very much so as a shared decision making when it comes to these conversations.
When the decision ends up ultimately being using a GnRH agonist to pause puberty, there are two main kind of classes. We have the intermittent injections or the implantable devices. The intermittent injections, there are monthly, every 3 month, and every 6 month forms that, sometimes it kind of is insurance dependent as to which one we go with or which one the family opts to do from that standpoint. Overall, it seems like they all work very similarly in regards to their efficacy. The injections are usually given by one of our endocrine nurses, or sometimes if the family is a great distance from our endocrine clinics, we sometimes try to partner with the pediatrician's office to see if they have that ability to give those injections. The implants are here in Cincinnati Children's placed under local anesthesia with our surgery team and implanted in kind of the bicep area in the upper arm. And they last usually 1 to 2 years. And that's great for patients, especially that don't want the shots as frequently as they're required. In those situations, because those are pretty effective at suppressing puberty, sometimes families kind of forget to come back to the endocrinologist because they're like, oh, my puberty is suppressed. And it's like we still need to kind of partner and monitor and keep talking about how we're going to long-term manage this. And so that would be one thing I would say, coming again back to partnership with the pediatrician as endocrinologists would be like, hey, if you know that your patient's being treated with a GnRH agonist implant, just making sure that they're also checking in with the endocrinologist once a year, and we can kind of teeter-totter our visits every 6 months would be a great way to keep a close eye on that patient.
And Dr. Ebo, you mentioned, with early puberty, with precocious puberty, long-term risks of not treating it, growth, early cessation of growth, the psychosocial impacts, absolutely. Are there any other long-term risks of not treating precocious puberty?
Yeah, I think there's some research being done into this now. Some of the things that I have seen, or just from looking at the literature, just some of the metabolic risks also. So some of impacts on cholesterol, your blood sugars. There is this theoretical impact of cancer risk as well that has been documented. And I think those are some of the main things that I've seen.
Yeah, I think the kind of the most prevalent risks are with true precocious puberty at an especially young age. As you mentioned, the compromise in final adult height can be quite significant. When it's precocious puberty, maybe just a year or so before the typical timing, certainly that can still have an impact on the psychosocial factors. As we know that women have like a finite number of eggs, and so if that process all starts early, could that also lead to an earlier menopause, long term, and the effects from that as well. So those would be the things that we would discuss as potential risk for not treating.
Is there anything that can mimic precocious puberty?
Yeah, so there's something called congenital adrenal hyperplasia, CAH, and this can lead to overproduction and excessive production of androgens from the adrenal glands, which can then present as early adrenarche. So having early development of pubic hair, auxiliary hair, body odor, some acne, and it may even trigger early onset of puberty. And so this would be something important to ask about in terms from a history standpoint, but also on your exam. And this would be be a time when you could get those androgen levels that we were speaking about to better assess whether this is you're seeing these clinical symptoms due to excess androgen production. As was mentioned, also hypothyroidism can present with early, profound, untreated hypothyroidism can present with evidence of early puberty just because of those TSH levels and them stimulating the FSH receptors, so kind of having that cross reactivity, and that's actually what can lead to that early central activation and then the pubertal symptoms. So those are two big things I would pay attention to. We briefly spoke about premature adrenarche because I think people often associate adrenarche with true puberty, and again, just to kind of emphasize that these are two different processes happening in the body. True puberty comes from the actual production of sex hormone, which is either estrogen or testosterone, and leads to those other characteristics that we've previously spoken about. Whereas adrenarche can be a benign process, and it leads to the hair development, body odor that we were discussing, and just these are two separate processes. Adrenarche doesn't necessarily put you at risk for having a true puberty or early pubertal development, but I think it's something important to talk about because I think you can see benign premature adrenarche, and people will often get that confused with the onset of true puberty. So just trying to differentiate those two things.
I'd like to just add with the CAH or congenital adrenal hyperplasia piece that can also have accelerated growth, so it can make it a little tricky to tease out. And that's, again, why I think sometimes you might also find that you need to add on those DHEAS levels, and because that's a adrenally specific hormone. In a girl, testosterone would be important to add in addition if you're seeing those features. And 17-hydroxyprogesterone is sometimes also something that we get in clinic for that piece. While these things are not true central puberty, definitely would need to be addressed and treated by an endocrinologist, so picking that up would be great. The other condition is something known as McCune-Albright syndrome, and that has a whole slew of endocrine features, but precocious puberty is one thing that can sometimes present. The interesting piece about that is sometimes those patients present with early menarche first, as opposed to not having that breast tissue. It can be a very rapid presentation. And going back to, your Gen Peds boards and things like that has that classic cafe au lait spot, coast of Maine appearance and things like that. So looking at the skin for those findings. On your labs, you would see in that scenario, actually the FSH and LH are suppressed, but the estradiol level would be high. And because that's more of a peripheral precocious puberty, again, can mimic true central puberty, can look like it, but it's not. Wouldn't be necessarily treated with the GnRH agonist, but certainly would require endocrine care.
Well, I've learned a lot today. Thank you guys so much for your expertise. Any last pearls of wisdom that you guys would want to share with the general pediatricians in the audience?
I think we want to acknowledge probably what everyone in the medical community has been noticing is that there seems to be more signs of early puberty in kids these days. And we looked at our data, again, even before 2020 to after the COVID epidemic, and we have seen about a 25 to 30% increase in referrals for concerns for puberty and new visits coming through for these concerns as well. The obesity epidemic is certainly a contributing factor to this, as we know that excess fat tissue can lead to some signs of puberty at the chest level with extra fatty tissue around the breast, and so really emphasizing the importance of that physical exam and palpation in that area. Early puberty can also predispose someone to early signs of adrenarche. And so, again, looking at that, and for our male patients especially, trying to make that distinction between, are you only seeing pubic hair or are you seeing testicular enlargement there? Finally, obesity can advance the bone age, often up to even 2 years older than the patient's real age. And so those things, I think, acknowledging the fact that it's true you may be seeing more of these kind of patients in your office and sending them our way more frequently as well, too. It's likely multifactorial with the changes in a nutritional status of a lot of patients, COVID kind of spurring a lot more sedentary lifestyles from that endpoint, and also concerns around that screen time and how that's affecting the pituitary system.
Well, Dr. Wasserman, Dr. Ebo, thank you so much. Appreciate all of your time today. For our listeners, as a reminder, today's episode is available for CME credit. You can find the links in the show notes. Also, today's discussion was guided by the Community Practice Support Tool on Precocious Puberty. You can find that on the CincinnatiChildren's.org website. Hope everyone has a great rest of your day. Thank you very much.
Thank you.
Thank you.